Today, we're going to dive deep into a very specific kind of pain. This isn't just any old backache. We're talking about chronic discogenic low back pain. And in this explainer, we are going to follow the entire journey, from that very first ache to the complex science behind it, and finally to the incredibly challenging search for relief.
You probably know the feeling. It's not that sharp, shooting pain down your leg. No, it's a deep, nagging ache right in the middle of your lower back. It's the kind of pain that makes sitting at your desk all day feel like you're running a marathon, or, makes just bending over to tie your shoes feel like a huge deal.
And if that sounds familiar, you are definitely not alone. Low back pain is this massive, global problem. It's actually one of the leading causes of disability, and it affects hundreds of millions of people. But what's really causing it for so many of them?
Well, while there are a ton of different reasons you can have low back pain, the research points to something really specific. For about 40% of people who suffer from it chronically, the main culprit is the intervertebral disc itself.
So to really wrap our heads around this, let's follow a pretty typical patient's journey. This is going to help us connect the dots between the symptoms, the science, and that big search for solutions.
So let's meet Alex. Alex's story is just classic for this condition. The pain is deep, it's central, right there in the lumbar spine. It really acts up after sitting through a long meeting or after a long drive. Sometimes there's this kind of vague ache that goes into the thigh, but it's not that sharp, clear-cut pain of sciatica. And importantly, Alex doesn't have any of those red flag symptoms that might point to something more serious going on.
Okay, so to figure out what's happening to Alex, we need to look inside the spine. What is actually going on inside that disc to create so much pain? A healthy disc, you can think of it like a jelly donut. Seriously, it's got this tough, fibrous outer ring, that's the annulus fibrosus, and a soft, gel-like center, the nucleus pulposus. It's a perfect design for absorbing shock and letting us move around. Now, when it's healthy, only the very outer edge of that ring has any nerve endings. But here's where things start to go wrong. Over time, or maybe because of an injury, this whole chain reaction kicks off. First, the disc starts to dry out, losing its bounce. Second, that stress creates tiny tears in that tough outer wall. Third, the body hits back with inflammation. And here's the real kicker. That inflammatory soup actually encourages new abnormal nerve fibers to grow deep inside the disc, into places they should never be. The disc literally gets rewired for pain.
Okay, so Alex has the symptoms, and now we get the biology. But how do you prove that one specific disc is the true source of the pain? This is where the diagnostic quest begins.
Alex's doctor starts with a physical exam, pretty standard. Then comes the MRI, which is amazing for seeing the anatomy. It can show a dehydrated black disc or even tears. But, and this is a huge but, lots of people have discs that look bad on an MRI and have absolutely zero pain. So how do you find the real culprit?
Well, to get a more definitive answer, doctors sometimes turn to a procedure called provocative discography. I know, it's a mouthful, and it is invasive, but its goal is actually really simple, to ask the disc directly if it's the one that hurts.
So here's how it works. Using an X-ray for guidance, a needle is carefully placed into the disc they suspect is causing the problem. Then, they inject a contrast dye which pressurizes the disc, and the patient, who's awake for this, is asked one critical question. Is that your usual pain?
And that answer? It's everything. If Alex says, yes, that is it, that's my exact everyday pain, that's a positive result. It's called concordant pain. But if it causes a different kind of pain or not much pain at all, it's negative. This helps them zero in on the exact level that's been causing all the trouble.
And it doesn't stop there. Afterwards, a CT scan can actually show how far that dye spread through any tears in the disc wall. This damage gets a grade using what's called the Dallas classification system. A grade 1 tear is pretty small, but a grade V goes all the way through. So you get a picture of both the pain response and the physical damage.
Okay, so let's say Alex gets a confirmed diagnosis. This is a huge moment. This is the crossroads, and now begins the journey through this maze of potential treatments, from the very basic stuff to the really cutting-edge options. Now, no matter what, the journey for everyone always starts here, with conservative care. This is the foundation. We're talking structured physical therapy, learning about how chronic pain actually works, things like cognitive behavioral therapy, and of course, anti-inflammatory meds.
But here's the tough reality. For a lot of people, this just isn't enough. The natural path of this condition can be pretty relentless. This quote from a long-term study is really sobering. It found that over 4 years, patients saw almost no improvement on their own. And that is exactly why patients like Alex often go looking for more advanced options.
And that brings us to a huge category of treatments, the ones that try to actually repair the disc. Regenerative medicine is probably the most talked about area. The idea behind injecting mesenchymal stem cells, or MSCs, is to add new cells that can hopefully grow into healthy disc tissue. Platelet-rich plasma, PRP, takes a different approach. It uses growth factors from your own blood to try and wake up your existing cells and calm down all that inflammation.
But what if you can't repair the disc? Well, the other major strategy is to try and block the pain signals instead. A really good example of this is a procedure called biacuplasty. In this one, 2 cooled radiofrequency probes gently heat the back of the disc. The goal is to basically zap those abnormal pain-sensing nerves, turning off the pain signal right at the source.
And believe me, the list of these pain-blocking strategies just goes on. You've got IDT, spinal cord stimulation, targeting a completely different nerve with RFA of the BVN. I mean, the sheer number of choices can be totally overwhelming.
So, with this whole menu of options, how does someone like Alex possibly make an informed choice? This is where we have to put on our critical thinking hats and look at the evidence scorecard.
Let's just look at the big patterns here in the evidence. See how procedures like biacuplasty and spinal cord stimulation have a moderate level of evidence? They can be considered for really tough cases. But now look at the repair strategies, like mesenchymal stem cells. The evidence level is currently rated as very low. The official recommendation? It really shouldn't be used unless it's part of a formal research study, at least for now.
So what's the big takeaway from all this? Navigating discogenic low back pain isn't about finding some kind of magic bullet. There is no single cure. The real goal is to use the best evidence we have a really honest conversation with your doctor about the pros and cons, and find a personalized path that makes sense for Alex's situation and for yours.
You know, this is a field where the science is always changing. There are new treatments popping up all the time. The challenge, for patients and for doctors, is to stay informed, to be critical, and to work together. So the question that we're left with is this. In a field where the evidence is always evolving, how do we best navigate this very complex path to relief?